Morning, everybody. I've got 10 o'clock. So we'd like to get started. And appreciate everybody coming out to listen to Jill and Selena on child abuse. I'm going to turn it over to Jill and let her introduce herself, and we'll get the day going.
Good morning, everybody. I'm Jill Brummett. I'm the nurse manager of the forensic program here at St. Elizabeth Healthcare. And if you're unfamiliar with our program, we are a 24/7, 365 team of nurses that will respond to all 6 of our locations for domestic violence, sexual assault, some child physical abuse, human trafficking, family violence, and elder abuse. So we are available for our patients and anybody that you want to bring in 24/7. We also do a lot of education with EMS for free. So if you think that your EMS teams need any education on child abuse, strangulation, domestic violence, sexual assault, we're more than happy to provide that free of charge too. So I'll let Selena introduce herself.
Hi everyone, my name is Selena McCormick. I am one of the coordinators for the program. So my role here is kind of to, provide direct patient care, but also, assist with some of the kind of day-to-day functions of the program. A little bit about my background. So I've been with this program for about 4 years now. Prior to that, I came from a pediatric forensic program out in Texas, where unfortunately we had a very high incidence of child abuse. So I kind of came more from the pediatric world. Have also done pediatric ER. I worked over in Cincinnati Children's for a while before transitioning here to the adult side.
Yep. So she brings a lot of expertise that we were kind of missing in our program with the child abuse. She's taught me a lot. So hopefully you guys will learn a lot today too. So we're going to turn our camera off just while we present so that it's not distracting. And then when it's done, we'll turn it back on for questions.
All right. So anytime I present on child physical abuse, I do like to spend a little bit of time just talking about the importance of this subject matter. So why is it so important that as healthcare providers, as first responders, we understand not just what child abuse is, but how serious child abuse is and how pervasive it is in our community. So child abuse is a serious public health issue. And again, today we're talking about child physical abuse. Our program here does not see child sexual abuse under the age of 14. We only see age 14 and over. So of course, that 14 to 17 age group are still children, kind of the adolescent population. But again, for sexual assault, we just see over age 14. For child physical abuse cases, we will see them on a case-by-case basis. So really, any kiddo under the age of 3 who presents to St. Elizabeth for child physical abuse will be transferred to Cincinnati Children's. And that is just because child physical abuse differs so vastly from adult physical abuse, right? So it's so important. I want you to think about this throughout the education, is just that children are not little adults. Children are completely different. And we know that in a lot of different ways, right? So we dose medication differently for children. We use different sizes of equipment for children. Kids are just different. Their bodies are different. And so it's really important to individualize care and tailor care specifically to kids, which is why we need to recognize that any little kids, so again, those ones under 3, need to be seen at a pediatric trauma center if they're presenting for concerns for physical abuse, because there's often a lot going on the inside that we cannot see on the outside. I could not even tell you how many times I've had kiddos come into the ER, little babies, infants who seemingly are totally fine on the outside, right? Not a single bruise. They're smiling, they're feeding, they're happy. But there's some inkling that tells us that we need to do child abuse workup, and we do a skeletal survey and they have 23 fractures and they start to go downhill really, really quickly. So again, those little kids really need to go over to children's. Above the age of 3, we will see those kids here on a case-by-case basis. We developed a non-accidental trauma transfer protocol in collaboration with children's to kind of filter through which cases we need to send over to children's. So if it's a case we're sending over to children's, our forensic team is not seeing those cases because we need to prioritize that transfer over to children's. So any kids over the age of 3 who have like serious head injuries, abdominal trauma, strangulation cases in like young kids and young teenagers, and any kids with just like, developmental delay, complex medical needs, or like just a need for like a high risk safety assessment or a pediatric consultation needs to go over to children's as well. So it's important for us to understand what our limitations are as a primarily adult facility. And again, just understanding that child abuse is a really, really serious matter, and those kids, it's just so different from any form of adult abuse. And some kids that we see will disclose their experience of abuse, but some don't, for a variety of reasons, and some can't. So really a suspicion alone is all that is needed to trigger community interventions, right? We don't have to prove child abuse, we just have to have a suspicion in order to move forward with a medical workup. And again, so why are we talking about this? Why is it so important that in this area we learn about child physical abuse? Well, in 2023, so annually there is a child maltreatment report that's generated nationally that kind of looks at the different states and ranks them on how well or how poorly they're doing with child abuse. So in 2023, which is when the last child maltreatment report was released, Kentucky had the 4th highest child abuse rate in the US. Prior to that, we were actually number 1 for many, many years, and that's number 1 in a bad way, right? So number 1 is in we have the worst rates or the highest rates of child abuse in the country. So we've kind of, our rates have dropped, which is great, but we're still doing an awful job because 4th in the country is still it's awful. So in Kentucky in 2023, 14.2 per 1,000 children were identified as having been abused. And so we can compare that to other areas here in the tri-state. In Ohio, for example, Ohio is doing better than Kentucky is. In Ohio, it's about 8 per 1,000 children. And then Indiana, again, a little better than Kentucky, but still not great, is 11.5 per 1,000 children. And we can compare that to the US average, which is 7.4. So all our states here in the tri-state area are doing worse than the national average, right? Because we have higher rates of child abuse. And when we're saying child abuse here, we think that's kids under the age of 18. But most victims that we see nationally are younger than age 1. So that's our really high risk population, is that under age 1, right? Our nonverbal kids. When we think about that in the context of like parental stress, right? Usually the most stressful time for parents is when kids are under the age of 1, right? Even and especially within that age group under 6 months. It's a really tough age, right? You've got fussy babies who aren't sleeping well, aren't feeding well. There's a lot of parental stress, financial stress, sleep deprivation. And so that's really where we see those really high risk kids. So again, we don't see what's going on inside of those kids, and adult facilities are not equipped to do the appropriate imaging for those kids, which is why we really need to send them to a pediatric trauma center. And so just thinking about that, right? When families are stressed, kids are at higher risk. So, why do we see such awful child abuse rates in this tri-state area? Well, we have a lot of familial stress, right? We have low education levels, which translate to low opportunities. We have high poverty rates. We have high drug abuse rates. We just have a lot of familial stress. And so while we have that familial stress, that's really translating to an unhealthy community, right? So as long as we continue to see these high rates of child abuse, we are building a very unhealthy community. And we know that child abuse is massively underreported. So these numbers are probably just the tip of the iceberg. These are just the cases that we're seeing are confirmed child abuse cases. And, we have a lot of cases that, are clearly child abuse cases, but, to confirm them, that requires an investigation. And we know how strained our Child Protective Service groups are across the country. So again, why is it important that we address child physical abuse? So if anybody's heard of the ACE study, the Adverse Childhood Experience Study, this was a landmark study that was performed, I think back in like the 80s, 90s, by the CDC and Kaiser Permanente. But what they saw is that children who have, so individuals who have had adverse childhood experiences, so basically bad things happen in their childhood, that can cause a significant long-term impact on health opportunity and well-being. So those individuals who've experienced, again, just bad things, right? Adverse experiences during childhood, that can cause lifelong issues. So we think about what those bad things are. That can be experiencing violence, so directly experiencing child physical abuse, child sexual abuse, experiencing neglect, or witnessing violence in the home or in the community. So I want you all to think about that in the context of child physical abuse, is even when we have kids who are not directly experiencing the abuse, so they might not be at the receiving end of the punches or the kicks, they might be witnessing that in their homes, right? So they might be witnessing one parent being physically abusive to another parent. And even just witnessing, even if they're not experiencing the abuse directly, that leads to the same poor outcomes as physical abuse does. So really, anytime there's violence in the home, no matter who that violence is directed towards, those kids are going to suffer tremendously, and they are going to suffer for the rest of their lives. And then outside of, experiencing violence, witnessing violence, there are a lot of other environmental factors in those kids' lives that can, lead to these poor health outcomes. So, really anything that undermines their sense of safety and stability. So that could be growing up in a household with substance abuse problems, growing up in a household with a parent who's suffering from mental health problems, and even parental separation, divorce, or household members being incarcerated. So we look at all of those things and, check. We have a lot of that in Kentucky and in the tri-state area. And again, these examples are not a complete list of adverse experiences. There are a lot of other traumatic experiences that can impact health and well-being. So, things like not having enough food to eat, experiencing homelessness, experiencing unstable housing, or experiencing discrimination. Again, really anything that undermines that child's sense of safety and stability, because that's what kids need. Kids need safety, they need stability. They depend on their parents, and ultimately their well-being and their ability to develop appropriately from a neurological standpoint is completely dependent on safety and on stability. So again, when kids have bad things happen to them, it can lead to chronic health problems. So if they're constantly experiencing stress in their home lives, they are going to probably grow up with chronic health issues. They're going to be more at risk for mental health issues, behavioral issues, substance abuse problems in adolescence and in adulthood, right? So these are issues that carry throughout their entire lives. It can have a negative impact on their education ultimately, right? So if they're having behavioral issues, mental health issues, we see these kids having ADHD diagnoses off the chart, that's going to impact their education. And if that impacts their education, then that's going to impact their job opportunities. Then that's going to impact their earning potential. So it's just kind of that snowball effect. And we really, really need to think about that when we're thinking about child abuse prevention and our response to child abuse. It's not just preventing a child from getting injured, it's preventing them from having these poor health outcomes for the rest of their lives. And we often see these kids having difficulty forming healthy and stable relationships. So, that kind of toxic stress from adverse childhood experiences, it really negatively affects kids' brain development. And again, it results in those behavioral issues. So what we see is a lot of kids trying to grasp at anything for stability and identity. So that might be a lot of seeking relationships outside of the home that could be unhealthy. And then if they've been exposed to unhealthy dynamics in their core relationships at home, they are desperately seeking out new relationships as an anchor, right? So they're desperately seeking out some kind of positive experience in their life. And often those relationships result in more trauma, more exposure to violence, drugs and alcohol, risky behaviors, trafficking, right? So really when we think about our problems in adulthood, the overwhelming majority of those stem from childhood, right? Substance abuse in adulthood is overwhelmingly a product of trauma, and that trauma is most likely trauma from childhood. So again, if I as a child live in an unstable and unpredictable environment where I don't know what's going to happen each day, you know, is today going to be the day that I'm safe? Or is today going to be the day that my mom gets punched and I'm going to get pushed? That really results in kids feeling threatened in their world, right? They then don't understand who they are in the world because they don't understand the world. And it's very much a dose response relationship. So the more adverse childhood experiences they're having, the worse their health outcomes are going to be. And adverse childhood experiences are the single leading cause of mental health issues in the US. So we look at somewhere like Kentucky, where we have a lot of people suffering from a lot of mental health issues, and we have a huge strain on the system because we don't have enough resources for them. The majority of that stems from childhood. So let's give a little example here. So you're walking in a forest and you come across a bear, right? A real bear, clearly not this AI generated bear. But you're walking in the forest, you come across a bear. Immediately your hypothalamus, so in your brain, it sends a signal to your pituitary gland and it signals to your adrenal gland and says, you know, release stress hormones, adrenaline, cortisol, go, right? So your fight or flight kicks in. Your heart starts to pound, your pupils dilate, your airway opens up, and you are ready, right? You're either ready to fight that bear or run from that bear. And that's wonderful. That's exactly what your body should do if you're in a forest and there's a bear in front of you. But the problem is what happens when that bear comes home every night and that system is activated over and over again, right? So when that bear is a parent who's living in your household, a caregiver, somebody who's supposed to be taking care of you, that constant activation of the fight or flight goes from being adaptive or life-saving to maladaptive and health damaging. And kids are especially sensitive to that repeated stress activation because their brains and their bodies are just developing. So high doses of adversity, right? So high doses of bad things happening in the home don't just affect the brain structure and function, but they affect the developing immune system, hormonal system, and even the way our DNA is read and transcribed. So again, if there's one takeaway from today, it's just how important it is for us to learn about child abuse and confront child abuse. So the president of the American Academy of Pediatrics says that adverse childhood experiences are the single greatest unaddressed public health threat facing our nation today. So, you know, why are we not talking about this all day, every day? Why do most people not understand what adverse childhood experiences are? And again, it's not just directly experiencing abuse. It can be witnessing abuse. So we have a child witness epidemic in this area. So, you know, statistics say that each year 5 million children in the U.S. are exposed to family violence. Well, we know that I personally don't believe in half of these statistics because we know it's way underreported. But what we do know is that a lot of kids are witnessing violence in their home. So we really need systems in place that serve child witnesses. And we do somewhat. We have mandatory reporting. So in Kentucky, healthcare professionals are mandated reporters of any kids who witness violence in their home. And then in Indiana and Ohio, we are mandated reporters for kids who not just witness violence in their home, but anytime we know there is violence going on in the home. And that's important, right? Because when we think of, you know, like our parents, our immediate family, they are supposed to be our foundational understanding of relational interaction. So how humans connect and treat each other, how to get what you want from other people. So kids raised in homes with domestic violence tend to really struggle with relationships outside of the home because they don't understand healthy boundaries. So they might be vulnerable to being taken advantage of and having their boundaries violated, or they might be going out and violating other people's boundaries and being aggressive because they are mirroring what's happening at home, right? If this works for my dad, why would this not work for me? So let's move on to kind of talk about like child physical abuse. So when kids are directly experiencing physical abuse, what is it that we are looking for? So as first responders, when we show up to a scene, what is it that we are looking for? So first of all, we think of like the history that's being provided by the caregivers, or maybe it might even be history provided by the child if they're verbal. But things that concern us are a missing, inconsistent, or changing history, right? Oh, the kiddo was covered in bruises. I don't know how it happened, right? Oh, the 2-week-old rolled off the changing table. Well, no, actually, he rolled off the sofa, right? Just inconsistent stories. Concerning caregiver behavior too, I would like to take that with a grain of salt. Parents are going to be, I feel like there's no appropriate way for a parent to respond when something bad's happened to their kids, right? Like if their child has a seizure, if their child is coding, there's really no appropriate behavioral response from a parent. But concerning caregiver behavior in the context of child physical abuse could be, are you showing up and mom and dad are high? Are they acting super sketchy? Obviously, we are not investigators. It's not our role to really like characterize that behavior, but sometimes it gives us an inkling to something that might be going on. Unwitnessed injury in little kids is concerning, right? So our bigger kids who can run and play independently outside and kind of not need that constant supervision, if they have an unwitnessed injury, that's typically okay. But our 1-year-olds who all of a sudden have those bruises and we have no idea how they got them, that's concerning to us. Unreasonable delay in seeking care, again, I take this with a grain of salt. I tend to think of this for like burns. Sometimes parents will show up days later with awful burns. They'll say, well, I was trying to take care of it by myself, right? Or a fracture. They thought their kiddo was fine. They thought they were exaggerating. They let them walk on a broken ankle for a couple days. Is that necessarily abusive? No, maybe not. But sometimes you do get those parents who are not taking their kids to the hospital because they want to hide something that's happened. Those kids who have lots and lots of ED visits for injuries, could it just be that they're kind of a wild, rambunctious kid? Absolutely. That's something we want to think about. If they're, constantly in here for head injuries, weird types of bruising, etc., we really want to kind of comb through those files and see exactly what they've been presenting for. I think for you all as EMS, like you typically know when you show up to the same home more than once. So if it's, you kind of show up to a home and you're like, oh man, we know these people, right? These kids constantly getting injured. Mom's always got bruises. We're constantly getting called here for 911 calls for violence in the home. That's something to think about, right? And then anytime there's been prior CPS or police involvement too, that's always just something to think about. Always can be a little bit concerning. We want to just have that differential diagnosis of child abuse in the back of our mind. So again, that's our history. Then we want to think of like our physical findings. So what are things that we might see on the child, injuries we might see on the child that alert us to this possibly being related to some kind of abuse? Any injury in a pre-ambulatory child should be concerning. So any injury in a kid who is not walking. Again, that's not an immediate automatic child abuse diagnosis, but we want that to be on our differential, right? So I have absolutely seen preambulatory kids who, sibling comes along and, hits them or drops a soda can on their head. That happens, absolutely. We just need to make sure we've got a good story to go with that. Injury to concerning locations. I'm sure everyone's heard of the 10-4 and the FACES P. We will talk about that a little bit more in a couple of the upcoming slides, just to have a little bit better of a visual when we're talking about that. Patterned injuries. So when we see those like linear pattern, loop pattern injuries, it looks like it's a child who's been hit with the belt, with a phone cord. Those are concerning to us, right? Is it illegal to physically discipline a child? Unfortunately not. But when you're physically disciplining a child with a belt and that's leaving injuries, that goes from discipline to child physical abuse. So something to think about. Injuries not consistent with the child's developmental capabilities. So think of, again, your 2-week-olds rolling off of changing tables. 2-week-olds don't roll. Can they have awful reflux and kind of arch their way off of a changing table? Yes, I have seen that. But again, we want to get a good history from the parents. Or similarly, we see this sometimes with fractures where, the parents will provide a history, but the fracture type doesn't match the mechanism of that injury. Multiple injuries in different stages of healing. So we really can't age or date bruises. So just because they've got a yellow bruise somewhere, a blue bruise somewhere else, doesn't mean those bruises are in different stages of healing. I think of injuries in different stages of healing, usually more as like fractures, which we would know about more when we kind of get to the hospital. Of course, injury that's not explained by a trauma history or medical condition. So those injuries that we don't have a good history for. And then failure to thrive. So those are our kids who, might be like severely malnourished. They're really tiny. Those could be medical issues, right? So we want to get them to a hospital for further workup. And again, that's where we really need those kids to go to somewhere like a children's facility, because an adult facility is really not equipped to do a failure to thrive workup. Those are usually kids that need to be admitted, need to be evaluated over time. We need to be able to study what their feeding looks like. So they need to be more in a pediatric environment. So we're talking about the 10-4 and ACEs. So this is not a diagnostic tool. This is just a really useful acronym that helps screen kids under 4 years of age with kind of any injuries. So kids are kids, right? Sometimes they'll play in ways that result in injuries. But those injuries are usually found on like bony areas of the body. So knees, shins, elbows, foreheads. But we do have other types of injuries that should be somewhat of a red flag for possible abuse. So when we think of 10-4, TEN is 10, torso, ears, neck. So any bruises to the torso, ears, and neck in a kiddo under the age of 4 is typically concerning. So the reason for that is those are protected areas. So they're just not areas that easily get injured. Can a child sustain injuries there? Yes, if we have a really good history to account for it, but otherwise those are concerning injuries. And then faces is, the frenulum, which is that little band of tissue that connects like the lips to the gums, the tongue to the base of the mouth. Injuries to the frenulum we often see from like bottle feeding, like forced bottle feeding, forced passies. Bruises to the jaw, to the cheeks, eyelids, or any like subconjunctival, so like eye injuries, eye hemorrhages. Those are all areas that are concerning, right? Because they're typically not a result of accidental trauma. They're typically not a result of playtime gone wrong. Those are more often related to non-accidental trauma or physical abuse. And again, that's under the age of 4 years. And then under 4 months, really any bruise anywhere is concerning. So those are kids, I'm sure everyone's heard the term, like if they're not cruising, they shouldn't be bruising. Kids under the age of 4 months are really just not moving in a way that will result in bruises or injuries. Again, can you have somebody taking, I've seen, some parents taking pictures of their kids and accidentally dropping an iPhone on the kid's head. Yes, that could cause a bruise. It's a pretty fair history. Again, little siblings dropping things on the child. As long as we have a history to account for it, it's, may not be concerning, but we want to at least consider it. And again, we talked about pattern bruising, right? So that's always going to be concerning for non-accidental trauma or child physical abuse. And then more red flag physical findings. So these are more things that you might see kind of once we get to the hospital, but intracranial injuries, abdominal injuries, areas of traumatic hair loss, genital injuries. And genital injuries are interesting because, yes, they can result from child sexual abuse, but I've seen genital injuries more in child physical abuse cases. So that potty training age in kids, so 2, 3, 4, is always a super scary age for me anytime I see them come in with injuries, because parents get pretty angry at kids when they have potty training accidents. And it kind of just goes in line with the cause of child physical abuse in general. A lot of times it's just unrealistic expectations for development. So, parents having unrealistic expectations, thinking that their children are going to be able to potty train super easily. Or, mom's working and she leaves the potty trained child with her boyfriend, and her boyfriend pissed because he has to go and, clean. He didn't sign up for cleaning up a dirty clothes, right? For having to clean up some kind of accident that the children have. So what I've seen often is like little boys having their penises slammed in toilet seats as a form of discipline. Obviously, that can happen accidentally too. Little girls having like their labia pinched as a form of discipline for a potty training accident too. Burns are hard ones. I would always send a burn 100% of the time to a children's hospital because they need a really good workup for accidental versus non-accidental trauma. Fractures under the age of 12 months, so in those non-ambulatory kids, are always concerning because, again, they're really not moving in a way that should result in injuries. And then, if you've got a kid with multiple fractures, bilateral fractures, symmetrical fractures, that's always going to be concerning for child physical abuse. And then within the fracture category, there are specific fractures which are considered like high specificity or low specificity for child abuse. Again, those are ones you want to send to a pediatric facility because they really need pediatric imaging, pediatric radiology, and pediatric ortho on board, and a child abuse pediatrician to look at those fractures and classify them. And then we always want to mention strangulation too. So strangulation does occur in kids, right? We do see unintentional strangulation in kids. So those kids getting caught in pacifier cords, window blind cords, toys, harnesses on high chairs and bouncy seats. You'll often see child equipment getting recalled, like the Mamaroo swing a couple of years ago was recalled because the straps had caused unintentional strangulation in a child. So, that definitely, most of the cases that we see documented in the literature are unintentional strangulation cases, but intentional pediatric strangulation in the context of child abuse does occur. We see it often. The problem is that kids aren't really able to tell us, and strangulation often does not leave any external visible injury, which is a whole separate lecture that we would be thrilled to give you guys if you would like it. Strangulation is kind of our bread and butter over here. I guess going back to the slide, one thing to mention, careful history and scene investigation are critical. So I think the amazing thing about EMS is that you guys are on scene, right? You see that scene, even though, obviously you're medical, you're not investigating, but you're able to see the environment, right? So you're able to see, okay, this child was, strangled by the cords in their Mamaroo. Is there a Mamaroo there, right? Or they fell off of this concrete wall. Well, is there a concrete wall, right? You guys are able to see what's in the home. You're able to document what's in the home, and you're really great at assessing your surroundings. But I'll also say, so we talked a lot about kind of external visible injury, different red flags, but it's important to know that no visible external injury does not mean no internal injury. And again, I will say this till I'm blue in the face, and always advocate for transfer of young kids to a pediatric trauma center, because I have had those cases of those kids who look perfectly fine. Maybe they're acting a little funny, maybe they're just kind of bottle refusing. But they're, have no injury on the outside. And then again, 23 fractures, a brain bleed, and they crump right in front of you. So don't let them fool you. Just because they look fine on the outside does not mean that they are fine on the inside. So when we're obtaining information for these cases, again, we're not investigators, but we do need to know what's going on medically. So, we just try to stay calm and conversational. If it's a verbal child, try to speak to that child and their caregiver separately. So we want to always give a child an opportunity to tell us what happened without their caregiver there. Because if their caregiver is staring them down, then the child may likely not share what's been going on. We also want to ask open-ended, non-leading questions because we're not investigative. Really, we have a duty to follow where the information leads, though. So if a child starts divulging something, then, we definitely want to ask more questions. But we never want to tell a child that their answers will be kept a secret, right? Because it won't be. If they disclose child abuse to you, then we are absolutely going to report that. Mandatory report. But of course, questions should be linguistically and developmentally appropriate. So, we want to talk to kids in a way that kids understand. So, using terms like boo-boos or ouchies, probably over injury or bruises. We don't want to be in a dominant position, so I always like to be like at a lower height than the child. So if they're on a stretcher, I'll kind of bend down or sit on the floor. I like to clarify unclear statements. So there's a well-documented strangulation case in the literature where a little child said, "Mama made me talk like a duck," right? Because his airway was being compromised and he felt like he was speaking like a duck. So, you hear kids saying that, and you're just like, oh, whatever, imaginations run wild, right? But we want to clarify, well, what was going on when Mama made you talk like a duck? Well, Mama had her hand on my neck. So kids can, often seem like they're rattling off useless information and using their imaginations. But if we follow those statements, they can often lead us to somewhere really helpful. We always want to make sure kids know that they're not in trouble, right? And then just because a child can speak does not mean that they're a child that you can get a good history from. And no disclosure does not mean that no abuse occurred, right? So even if they say that nothing happened, that doesn't mean that nothing happened. Again, we want to get them to probably likely Children's Hospital where they can have more of a thorough workup. So like over at Children's, the social workers there can actually are trained in forensic interviewing techniques. So what are some questions that we can ask kids, right? So just what happened, right? What happened to you? How did you get those bruises, or how did you get those ouchies or boo-boos on your body? Do you hurt anywhere? Where were you when that happened? Did an adult see that happen? Do you feel safe at home? Has anyone ever done anything to your body that you didn't like or that hurt you, that scared you? What happens when you get in trouble? So just really easy, open-ended questions, right? I'm not going to ask a child who gave you those bruises, right? I'll say, how did you get those bruises? But just nice, open-ended, non-leading, non-investigative questions. And I encourage you, document what those kids tell you, document what you ask them, document for these cases. And sometimes, you can't get a good history from a child for, whatever reason. They may not be verbal. They may just not be able to provide a good history. They may be scared. So we can, ask the caregiver, say, what happened, right? What do you think happened to your child? Sometimes when you say, what happened, they'll kind of dance around it. So I'll say, well, what do you think happened? For parents with young kids, those kids under 1 who are super high risk, they'll say, what do you do to calm your baby? What do you do if that doesn't work? For those really fussy babies who are at really high risk of being injured. When your kid's troublesome, what do you do? How do you discipline? What kinds of things do you find yourself saying no about? How are you guys managing your kid's behavior? Do you feel overwhelmed? Has CPS ever been involved in your home? Have the police ever been called out to your home? I always screen for domestic violence. So anytime there's a child physical abuse case, I always screen for domestic violence, always ask the parent if they are experiencing violence. Automatically, the answer is usually nope, because they don't want more people looking into their homes. But we always have to just be creative in asking questions in a way that are non-judgmental or negative. But of course, understanding that this isn't an investigation, right? We're trying to figure out what's going on medically. So, when we show up and there's an injury or they say there's a fall, well, we want to know our medical questions, right? So, well, what time did it occur? What time did the head injury occur? When did the symptoms first start? What were they? Have they progressed? How high was the fall? What type of flooring did they fall into? Did they hit their head on the way down? Did they cry immediately? Those are medical questions, right? They're not investigative, but when you start asking all those questions, a lot of times the parents are all of a sudden like, oh, because they've not really got their story straight, right? They've just said, oh, we'll say he fell, but then they have a hard time answering these questions a lot of the times. So for our assessments of these kids, I can't stress enough, we need to look at these kids from head to toe. And to look at them from head to toe, they need to be completely undressed. Obviously, am I going to completely undress a 13-year-old girl? Maybe not, right? But like our little kids, our kids in diapers, our younger kids, we do want to completely undress them, right? Because those injuries are often going to be in hidden areas. You know, when parents chronically abuse their children, they're pretty smart about it. They want to hit them on the butt, on the thighs, so that they can put clothing over them and send them to school without getting in trouble. Right, so we want to take the diaper off, look in between the legs, look in between the butt cheeks, completely do an actual head to toe assessment. And of course, we'd explain to a child why, you know, what parts of the body I'm looking at, why it's okay that I'm looking at their body. Make sure they understand it's not okay just for anyone to undress them and look at their bodies, right? We need to make sure that they understand that. I would consider the use of a chaperone, especially for like opposite sex kids. When we're doing a head to toe exam, always remember your cavities too. So look in the ears, look in the mouth, and often letting the child be helpful and be involved is really going to help the process. So what next? If you have concerns for child physical abuse, so if you show up to a scene and there's concern for child physical abuse, make every effort possible to transport that child to a hospital. Remember, we talked about mandatory reporting guidelines, so follow your guidelines. We talked about, you know, if there's concern for child physical abuse in the home, there might also be concern for domestic violence. So it's just a really good opportunity to screen. But you will not get in trouble for making a report in good faith. A suspicion alone should trigger a report. So something to think about when we think about mandatory reporting guidelines is, you know, we are mandated reporters of child abuse, right? Mandated reporting is not something that we should just rely on, right? So if we have a case and, you know, parents are refusing to come to the hospital, or they're in the hospital and they're, you know, leaving AMA, we can't just rely on saying, okay, well, we'll just place a report to CPS and CPS will deal with it, right? Because when we think of CPS, we think, oh, well, what's going to happen, right? Are they just going to show up at the home and intervene? No, because CPS response times are awful. So this is from that child maltreatment report that I talked about from their 2023 results. And it looks at CPS response time. So the time that it takes somebody from Child Protective Services to respond to a case, if they even accept a case. So in Kentucky, it takes 246 hours. That is about 9 days for Child Protective Services to respond to a call. So we have the third highest response time in the nation, highest equaling slowest. So what that means is that if you are concerned for that child and you place a report to CPS, it's going to take about 9 days for somebody to actually get out and do a welfare check on that child and see what's going on in the home. So it is not something that we can rely on, unfortunately. Indiana and Ohio are a little better. So Ohio takes about 21 hours for CPS to respond, and Indiana it's 46 hours. So definitely better than Kentucky, but still. A lot can happen in 21 hours, a lot can happen in 46 hours, and a lot can happen in 246 hours. So we cannot rely on Child Protective Services as our safety net for these kids, unfortunately. But before I move on to case studies, just a few pearls of wisdom. Documentation has the potential to be evidence. So if we can't get these kids to the hospital, your documentation on scene might be evidence if something bad happens to these kids. So document. Document what you ask, what you hear, what you see. Document what the child says, what the caregiver says happened. Document their behaviors. Document injuries really well. You know, offenders, which, you know, often parents, unfortunately, can get their stories together really quickly between home and the hospital. So documentation changes are really important. So if you all document one thing and then they tell the triage nurse and the ER something else, and then they tell the provider something else, those are all really important in the context of an investigation. Is those different, you know, once the parents start getting their stories together and deciding that they're going to change their stories, that can speak volumes for these kids. And then in any situation of violence, always ask about head, neck, and kids. So injuries to the head, strangulation, and were there kids present, were there kids in the home, were there child victims? And then only ignore your good feelings, but never ignore your bad feelings. So you all, you know, you show up to so many different scenes. You're really good at reading the room, reading the environment. So go with your gut. If you think something's wrong, it probably is. I'll move on to a couple of case reviews. I'm going to pass this over to Jill.
Okay, so we'll kind of put into practice everything that Selena had talked to you about and go through. We have 3 case reviews on some kids that we saw here at St. Elizabeth. So the first one is a 9-year-old. He was brought to the emergency room by his biological father with the chief complaint of assault. He does live with his biological father, and his biological mother does have unsupervised visitation rights, previously supervised only, but she was able to get the unsupervised visitation. Patient was staying overnight with mom, and called his dad saying that his mother heard him and he wanted his father to pick him up. So clear outcry for some sort of an assault. So Selena actually happened to see this patient. So when she came in, here was her question. So this is how she documented. She put her question that she asked the child so that there can be no question that she asked him a leading question. So she said, can you tell me what happened that brought you here today? And he said, my mom, she grabbed like an air freshener, then she threw it at me and it hit my eye. We were at her boyfriend's house downstairs. She was being so rude to me, and I said, I'm about to call the cops. And she came up to me and said, give me your thumb. Then she was like, give me it. So I put my thumb in her hand, and she was reaching for the air freshener. When I see her reaching for something, I thought she was reaching for my thumb, but she was reaching for the air freshener. I started crying so hard, and I started bleeding. It hurt, and I couldn't stop crying. So then again, Selena asked, kind of another open-ended question. Has anything like this ever happened before? And he said, she gives me butt whoopings. She always threatens me and stuff. She's always be like, I need a gun to kill my own child for no reason. She always says my sister is the good girl and I'm the bad boy, and I don't know why. So those are direct quotes from the child, and she put those in direct quotation marks. So again, she's asking a few more questions. What does she give you butt whoopings with? A belt. She says, when I give you butt whoopings, I'm going to whip you with the metal part. She says stupid stuff, and she be mean to me for no reason. Has your mom ever put her hands on your neck? No, I do not remember her doing that to me. Remember, we always want to think about the head, neck, and kids. Do you feel safe at home with your mom? Not really, because the way she acts. Do you feel safe with your dad? And he said, yeah. Has anyone else ever done anything to your body that you didn't like, or that hurt you? And he said no. And Selena did her interview question, or not interview, her narrative history questions with the father not present in the room. So when she went to do his head to toe assessment, he did have a laceration there on the side of his, looks like his left eye, which corroborates with his story that mom hit him with the air freshener on that side. So she took a few pictures, not we, and it looks like they'd already glued it at this point. So yeah, but he definitely has all that swelling and bruising too to the lower eyelid as well, and maybe even the upper too, some. And then he did have some blood on his shirt where when she struck him and caused the bleeding, it was on the shirt. So it just, again, it's another piece of collaboration of the child's story. So the assessment was that laceration to the outer corner of the right eye with the surrounding erythema and swelling. The bleeding was controlled. The wound edges were approximated with surgical glue at that point. He did have periorbital edema and red and purple bruising. So she documented all that under her assessment piece, which is, again, just to reiterate why it's so important to document injuries. Patient is unable to fully open his eye, so that was a good assessment by Selena as well. And then he definitely had a clear outcry of child physical abuse, and it was consistent with the injuries, what he told Selena. So CPS and law enforcement were notified. Father was very protective and proactive while Selena was in the room, so she had a really good feeling about him. He states he will not allow the patient to have contact with his mother. So he was discharged home with father. And then we did do a referral to our Northern Kentucky Children's Advocacy Center. And we did confirm that they received a follow-up call from Children's Advocacy. And then at this time, there was no psych or behavioral concerns from the assault. Okay, case number 2. This was a 2-year-old that was brought in by biological mom for ear bruising. she had an open CPS case already for maternal substance abuse. So, you know, you can imagine there's 3 kids that live in that house, so they probably have quite a bit of ACEs. But mother was instructed to bring him in by her CPS caseworker. So she was proactive, noticed the bruising, called Child Protective Services, and they instructed her to come to the hospital. There was really no history to account for what had happened. So again, like Selena said, you know, if there is concern for child abuse, um, we can screen mom also for domestic violence. And she denied any history of domestic violence or previous history of child abuse or unexplained injuries. So kind of some unique considerations with this 2-year-old was that he was a little developmentally delayed. He was nonverbal. I think he said a few things, but not many at all. And then they had that previous history of CPS, and mom and the child live in Catholic charity housing with a 1-year-old half sister, a 7-year-old half sister. And then the patient's stepfather lived out of town, but mom reported that he would come by on the weekends. So again, we couldn't really get that clear history from that 2-year-old because of his delays and his nonverbal. So we kind of asked mom, like, can you tell me what brought you here today? And she said she noticed the marks on his ear on Sunday. And I asked my husband, what are those marks? I have a voice message of him saying, I ripped off his shirt too hard. I asked why he did that. And he said it was because he puked. I asked what happened to his ear. And he said he didn't know. I'm pretty sure it happened Saturday because Friday she didn't see anything on him. And then Saturday they went to the doctors to get herself and her daughter on antibiotics. And when we got back home, her and her daughter had actually went to sleep, and stepfather was caring for the 1-year-old and 2-year-old most of the day. So we asked, what do you think happened to your child? And she said, it looks like someone went like that. And she simulated hitting an open hand. One person says it looks like he fell. Another said it looks like he was pinched. I know he has sensitive skin because he bruises easy. So then we further asked, do you have any concerns for your children while in the care for your husband? And she said, no, I didn't at all. I'm surprised this even happened, and I'm kind of upset about it. The patient has a speech delay, but usually he will say, yeah, if I ask him a question. But for this, I asked him, did stepfather do that to your ear? And he gets all scared in his face and he doesn't answer. I know daycare didn't do it because when the bruises showed up, the only people that was around the weekend were older sister, younger sister, and then stepfather and me. So as we start to examine the 2-year-old, this is the bruise that's behind, looking at it from behind the right ear. So he has some redness, you know, on the neck behind the ear, and then he also has bruising on the ear. Almost looks like he has a little petechiae too, and we'll talk about why we think he had some petechiae. Just another shot of the ear bruising from behind. And then pretty significant bruising to the ear there. And some petechiae. And then looking at it from the front, it was pretty significant, that deep, dark purple bruising that, you know, is very suspicious for non-accidental trauma. Then we looked at his other ear too. Looks like he might have a little petechiae on there, but he really didn't have any bruising or anything else there. So as Selena said, we really need to get these kids undressed because we need to look at their entire body. So we started to get him undressed, and then we noticed that he did have some bruising on his abdomen, and he actually had bruises on both sides of his abdomen. And then also he had bruising on his buttocks. So that was very significant. If you remember the 10 and 4, the torso, ear, and neck under the age of 4, he had ears on his torso and his ears and his neck. As we were examining him, the doctor came in and said that he had a displaced right parietal skull fracture. At that time, we were kind of keeping kids over. We hadn't developed our protocol, the transfer protocol with Children's yet. So the doctor did call to Children's Hospital, and they said, if you can do a skeletal survey and some labs, then you can see the kid there. And it happened that day that there was a radiologist that was able to read pediatric skeletal surveys. So that was unremarkable. He didn't have any other injuries. And then his labs were unremarkable too, since he had that abdominal trauma. But it was also highly concerning for that non-accidental trauma and possible strangulation or suffocation. Yeah, go ahead.
For those labs, something important to think about is another reason we need to transfer these kids over to Children's Hospital. It was pretty clear that this kiddo had probably been injured. However, I have seen in the past, kids come in with tons of bruises, and we immediately jump to, oh my gosh, physical abuse, something happened. And then we do a lab panel, and it turns out that this is like a newly diagnosed leukemia or a newly diagnosed bleeding disorder. So it's really important to have a really full medical workup for these kids, because child abuse should not be the first thing we jump to, right? It's part of the differential, but we also have to rule out again bleeding disorders, anything else going on, which is why any kid who's getting a full child abuse workup at a pediatric facility will get a CBC, CMP, lipase, urinalysis. Depending on the hospital, they may get additional like tier 1 or tier 2 labs that look at things like von Willebrand's, factor 9, just to work them up medically for that too. So again, just the importance of making sure that they go to a pediatric trauma center with an established protocol for what, labs and imaging to do.
Which we do not have at St. Elizabeth's, is why it's so important to transfer to Children's. And then, the child was highly concerning for that non-accidental trauma just because he had the 10 and 4, he had that. And then also, we saw that petechiae on him. And if you remember, Mom disclosed that stepfather had said he ripped his shirt off. So a lot of times strangulation in children can be from clothing, where they just, rip it off too hard, and it actually will cause petechiae, and it looks like strangulation. We'll never know what happened to him because he couldn't tell us. But we did notify CPS, and the CPS worker was already aware since she had called and told her to bring her to the hospital. Law enforcement was notified, and also the caseworker actually came to the ED. She cleared Mom to take the kids home with a clear safety plan in place that stepfather was not to be in the home with the children. And Mother agreed to that. And then case number 3, this is a 13-year-old, so we kind of wanted to show you a little bit of the gamut of the ages. She was brought in by her biological mother with chief complaint of assault. Patient and her mother were currently living with her maternal aunt. And patient's mother states she owns a home, but they currently didn't have working heat or electricity. The patient reported that her aunt had strangled her today. So again, we asked, can you tell me what happened that brought you here today? Very simple question. She said, I woke up and was told to do the dishes, and I did. I went back to the room. She said I didn't clean the counters or stove. I told her to get her favorite boy to put dishes away. She pushed me, and my head bonked into the microwave. She told me to go to the room. I told her no. I have to take my medicine. She pushed me to go back into my room. We both fell to the floor. I bit her on her thumb to get her off me. She was trying to choke me. She kind of choked me. When we were on the ground, she was basically hugging me, like choking me. I was getting away from her. She came into the room. She pushed me. Then I fell on the ground. She stomped on my chest. Then I ran outside and called the police. So clear outcry for strangulation and physical abuse. So this was part of her assessment. She did have some redness and abrasions on the right side of her neck, kind of towards the back, posterior. A little bit closer image of that. And linear. This would be the other side of her neck. She just had a little bit of redness kind of up in her hairline here, and a little redness there, which is consistent with strangulation. So red linear abrasions to neck. She had the clear outcry of child physical abuse, and her injuries were consistent with her history of strangulation, or choking is what they normally will call it. Her disposition, pretty straightforward. We notified CPS, law enforcement. Her aunt was actually arrested, and then we involved social work to assist with that housing and their financial concerns since they didn't have heat or electricity. All right, I think that's the conclusion of our presentation. We'll turn our camera back on if anybody has any questions. There's our email addresses and our phone numbers. too, if you have questions ever or concerns, if you come on scene with a child, or if you want us to come do that free education, we're more than happy to. So if anybody has any questions, you can unmute yourself. Maybe, can they unmute themselves, Tony?
Actually, they can't, but we've got the chat and the
Okay.
question and answer
Oh,
area open. So if they want to type something in, I did put my email down as well.
okay.
And then I'd like to take another maybe 15 minutes and add a little bit to this talk to cover the requirements for the Kentucky Board of EMS Pediatric Abuse Head Trauma requirement. In Kentucky, all EMS professionals are required to have this specific class on pediatric abusive head trauma. I am one of the instructors, so I looked at presentation the state has, and I had your presentation before, so I knew there was quite a bit of what you cover is required in the state. I just wanted to add a few things to meet that up, so that those Kentucky EMS professionals, if they want the certificate for the pediatric abuse of head trauma, I can get it to them and keep them all up to date. I'm hoping just another 10 or 15 minutes. I'm going to jump through the slide presentation because, like I said, most of it's been covered by the two of you, and I really appreciate your time and expertise on this. So without further ado, I'm going to jump over and take
Yep.
control, and
Yep.
thank you again.
Thank you.
Thanks, Tony.
Yep. Okay, good. So, like I said, just I'm going to kind of buzz through these slides because most of it's been covered, but I just want to make sure that we hit all the objectives. And those objectives are describe abusive head trauma, associated injuries, review statistics, understand medical evaluation, discuss some case scenarios, and prevention strategies. As you know, the statistics we've talked about, evaluation we've talked about, uh, scenarios. I thought those were some good scenarios. So we use the preferred terminology of non-accidental trauma and abusive head trauma. And it's not shaken baby syndrome anymore. We've gone on and looked at through the statistics. Like she said, she had statistics from the 2022. These are from 2020. Not nearly an improvement that we had hoped, but it's all still good. This class specifically kind of goes down the area of brain trauma, the injuries, because it's very rare for a child to die or become permanently disabled from the first time they're abused or neglected. So this is where EMS, care where you are in the country, where you are in the world, if your gut is telling you something, this can be the step that prevents that from the ACE situation going to more mental into a physical disability. Almost 100% of the kids who are in foster care that is through the state of Kentucky are there because of physical abuse. So if we can pick it up, trust our gut, it can be a major impact on the kid's life. She talked about reporting requirements. Again, every state has reporting requirements. In Kentucky, it is any person who knows or has reasonable cause to believe that a child is dependent, neglected, abused, shall immediately cause an oral written report to be made to a local law enforcement agency or the Department of Kentucky State Police, the cabinet or its designated representative, the Commonwealth Attorney, or the county attorney by telephone or otherwise. Any supervisor who receives from an employee a report of suspected dependency, neglect, or abuse shall promptly make the report to the proper authorities for this investigation. If the cabinet receives a report of abuse or neglect allegedly committed by a person other than a parent, guardian, or person exercising custodial control over the supervision, the cabinet shall refer this matter to the Commonwealth Attorney or the county attorney and local law enforcement agency or the Kentucky Department of State Police. So it goes back and it says that you have to report it to one of those people. Going to the hospital, and I will tell you this, Indiana, Ohio, going to the hospital and telling the nurse, hey, I think this child has been abused, that does not meet the reporting requirements. You have to report it to the law enforcement. It has to be documented. They should get 5, 6, 7 reports if it's truly something suspicious. The ER staff has to report it. So they should receive individual reports from you. Telling the doctor is not covering your requirement. You need to make proper notification. Get your supervisors involved. Make sure your documentation's in place. So, pediatric abuse head trauma. What does shaking? How does it work? Why does it cause these injuries? So our brains, as we develop into adults, they become pretty solid in there. But as a child, that inside of the brain is smooth and the inside of the skull is smooth. The brain has a lot more liquid uh, to it, so it's uh, very sloshy. So when you take a child and you grab them and you shake their head goes back and forth. Well, inside that skull, there's room, and it's slick. There's a lot of moisture, so it's very jello-like. And we have these little tiny bridging veins. So veins are slow bleeders, right? And we have these little bridging veins that stretch. And over time, they can rupture and then bleed. And that leads to our subdural bleeding. Remember, subdural is our slow, insipidus little bleeds. It takes time, days. It starts with the headache and it gets worse. So what happens is that brain is moved back and forth, and those bridging veins are stretched and ripped, and they start to bleed over time. It's usually mostly found during the CT scan because it's over a slow period of time. But that, um, again, some of the injuries to look for, reminders, retinal hemorrhaging, other rib fractures, other fractures, bruising, internal abdominal injuries. And again, as Dr. Brummett talked about, nothing. A lot of times these kids come in and they look perfectly fine, but your gut is talking to you and it's telling you something. Pay attention to it. So EMTs and first responders, again, we are in that unique position to help recognize and intervene in these cases. The more we pay attention, the more we listen, the more we chart and actively ask those questions. Tell me what happened today. I really like that's a great way to start out a question. It forces them to start the story. And as you're listening, you're paying attention, even taking notes so that if at the hospital the story has changed completely and believe it or not, that happens occasionally. You've got, well, they told me this. So it brings those questions into place so that you can intervene and help these children so that it doesn't get worse for them. Talked about the 10-4 rule, bruising, all different, the history, the exam. So these next couple slides are photographs from cases. I'm gonna show them, but not spend too much time, just because we want you to think about how bruising should be on the body, because it is not a normal thing, especially for a 4-month-old. Any bruising whatsoever on a 4-month-old or below, it's that should raise flags. 4 years old, we have some active kids, and there can be some bruising, but bruises like these, there's no acceptable way that these happen. This wasn't kids playing. This is obvious abuse. And unfortunately, sometimes we are gonna see these because the child has become sicker from the original assault thing. So we're gonna see these bruises in these stages. Tiny little bruise. This is when they were brought in to a doctor's office. This tiny little bruise was all that was there. This is a couple, uh, this was, yeah, a week later. Child's in ICU, hooked up to a bunch of different things. Would you have picked that out? Would you have noticed that? I hope so. Ears again. This was reported that the child stepped on a Lego. The story doesn't match, right? Again, any bruising. Look at that tiny little bruise on the back of the leg. Babies don't bruise. Little babies just do not bruise. There has to be some significant force to cause that bruise. That's not from changing a diaper and they wiggled. Frenulum tears. She talked about the frenulum. The P, the pattern. That one's a little bit harder to see, but you can see there's a pattern. This was a brush, a hairbrush. So remember this, stick that 10-4 faces P in the back of your head. If you see bruising, start asking some more questions, start documenting, paying attention. Normal bruises, they happen, but they're usually on the front of the body, over the bony prominences, again, the forehead, knees, shins, elbows. Talked quite a bit about pattern. I mean, that's an obvious handprint. There's no question. Bite marks, again, another form of abuse, another pattern type bruising. So, summary of the bruising. Bruising in infants is a significant indicator of abuse. must be reported, and make sure you're involving the police. They need to be medically evaluated. She talked quite a bit about taking children over to UC. They have more resource, or I'm sorry, not UC, but Children's. They do have more resources. It is great having such a local resource in the area. St. Elizabeth and other hospitals have mutual aid agreements, just like ambulances, with Children's to make sure that those resources are available for us. So take advantage. Make sure you're taking your patient to the appropriate hospital. Talk quite a bit about the medical evaluation. Again, factors leads to these abuse cases. Unrealistic expectations of child's behavior. That is the number one. Just you have this great thing in your mind, and kids will mess it up. Not the true thing, but you have to understand that, especially nonverbal kids, they have no way to communicate with you. And as they're learning and speaking, they're trying to communicate with you. Patience is more than a virtue with children. There's usually a history of abuse in the past with one of the caregivers, and they the history that you get from the family is again is important as part of the documentation. Normal characteristics of an abused child are 0 to 3 of age. And again, that's because it's more common in that age group, or they're not meeting the expectations. There can be multiples, colic. If you've ever had a colic baby, you know how that can truly be a challenge for any adult. Physical developmental disabilities, chronic illnesses, and the IVF is one of the things that a child born from IVF has higher incidence across the nation of being abused, and it has to do with the expectations again. Went through all of this, now I have a baby, and it's not meeting my expectations. So in all the pictures, if you notice, there's not a particular skin color, there's not a particular race, there's not a particular socioeconomic group. Abuse happens in all levels. It happens in white families, it happens in Black families, Asian families, Hispanic families. It happens in two parent families, middle class, well, those with resources, those without resources, young, old. It happens across the board. Don't let someone who looks like you tint your behavior that, oh no, it couldn't be because they're like me. I'm a good person. They must be a good person. Keep your spidey sense going and pay attention. Documentation. First responder documentation is probably one of the most crucial components of the legal case because we were there, we were on scene. What was the temperature? What did it look like? What did it smell like? All of those things are things we want to make sure. Document what you see, any unusual behavior. Document statements, word for word. Remember, use quotes if we can. Pass along your concerns to the receiving hospital, definitely. But make sure your Department of Community-Based Services and law enforcement are notified as well. Document any visible injuries you have. Now, don't take pictures. Don't use your camera. Don't use the squad camera. Don't take pictures. You just don't need that on your phone. Those phones will become evidence, and you won't, if you do take pictures, you won't get your phone back. So a new phone's, I don't know, what are they, $1,500 now? You won't get your phone back. Make note of any bleeding. Exercise caution when asking questions. Remember, we want to try to keep this as civil as possible so we can take that child and put it into a safer environment. So observe, listen, report. Make sure you document any threats made to you, any statements, and follow your departmental policies on transport and any kind of extra documentation you might have. We went over some scenarios. Hit the wrong button. So our final notes, always keep abuse in mind. Be aware of common scenarios. Be an active observer. Document, document, document. What can we do? Educate. If you're a parent and you know of new parents coming online, help them understand crying is normal. It is the only way the child has to communicate. Provide tools for soothing an infant. If you have tricks in place, share them. A lot of abuse comes from not having the resources. You know, if you're a single mom and you're stuck with a crying child for days at a time, you haven't slept, if there's no break from any of it, that can be a true drain on your psyche. So if you know somebody like that and you can offer 2 hours of respite care for them, let them get a nap in, that can be an amazing gift. Help parents understand what are reasonable expectations. You know, yes, my child learned to walk at 3 months old. Well, that's not a reasonable expectation. Understand and share the good and the bad stories of raising a child. Early recognition, if we can recognize it early, maybe we can prevent the head trauma that leads to the physical disabilities. There's still going to be the emotional disabilities and the lifetime of care that's needed all around. But to prevent the physical, mental abuse from continuing is one of our most prized jobs. If you're in Kentucky and you need to report, the number is 1-877 KYSAFE-1 or Safe One. So 1-800 or 1-877 Kentucky Safe One. You can remain anonymous if you want. I've always included my name just so that I could document that I reported it. If I have that strong of a belief, I'm strong enough to say that I want my name be known so that if it's called to court, I'll be happy to testify. And having good documentation will make that valuable. Give facts when reporting. Simple facts. I have a 4-month-old with bruises to the head, abdomen, and buttock. These injuries seem to be indicative of abuse as this child is young. Specify your concerns. Request a callback. Ask the hotline worker to make sure that it's been documented. They will generally request further information so they can get back with you. So our take-home message is abusive head trauma is the most dangerous and deadly form of child abuse. Experience tells us that we often fail to recognize early warning signs, and we therefore miss opportunities to intervene and prevent further harm to abused children. We in EMS all play a vital role in observation, documentation, and reporting. The absence of risk factors is not the same as the absence of risk. 10-4, the faces P bruising rule. Remember that, use that. Long-term effects from abusive head trauma vary from subtle learning and behavioral issues to complete dependence for all care for that child, education of caregivers regarding techniques for soothing a crying infant and the dangers of shaking can be an effective prevention tool, as well as for promoting healthy caregivers and relationships and early recognition and reporting. And lastly, thank you. Appreciate everybody attending today's lecture. The next one will be in June. I'll send out the information. I believe it's going to be Dr. Cunningham from Ohio. She's going to talk on some worldwide information on EMS. So thank you for your time. Again, my email address is tony.shaban@stelizabeth.com. If you want a certificate, the actual pediatric abuse head trauma certificate, send me an additional email or whatever, and I'll make sure I get that to you. I'll send out a certificate for the class. And if you would, send me your rosters. I'd like to know how many people are attending these. Let the speakers know that their message was heard by few or many. And again, thank you for your time. If you have any questions, please feel free to reach out. I'll stay online for a little while longer, and I'll see you all soon. Thank you.